Okay, good morning, good afternoon, good evening, wherever you are. Welcome to another YouTube live stream from Intensive Care Hotline and Intensive Care at Home. Today's topic is my fiancé has been in ICU for 19 days and was intubated pretty much as soon as we got to the ER. They just did a tracheostomy yesterday. What should I be doing next? So that is today's topic, and we'll just give it a couple of more minutes and let people come in before we get started on today's topic. My name is Patrick Hutzel, and I'm your host today with the intensivecarehotline.com YouTube live stream, and we answer all questions for families in intensive care that have loved ones in intensive care. We go through a series of questions today. I do these YouTube live streams usually once a week, so you have an opportunity to ask me live on a show, but I also almost recap a whole week. Often, what questions we're getting during the week. Sometimes I answer them in a quick tip video. Of course, we talk to clients one-on-one all the time as well, but it's also easier for us then to capture a bigger audience and provide more value to families in intensive care. That's always our goal. We want to be the best blog on the worldwide net for families in intensive care, and we want to provide the most value for families in intensive care. So you may wonder what makes me qualified to answer questions for families in intensive care on a live show. My name is Patrick Hutzel. I am a critical care nurse by background. I have worked in critical care / intensive care for over 20 years in 3 different countries. I have worked as a nurse unit manager for over 5 years in ICU, and I have been consulting and advocating for families in intensive care all around the world for the last 10 years. I've been online since 2013 at intensivecarehotline.com. I'm talking to ICUs and families in intensive care almost every day, and I talk to them all around the world. And I'm also the founder and managing director of Intensive Care at Home. You'll find more information at intensivecareathome.com. With Intensive Care at Home, we basically provide an intensive care substitution service in the home for predominantly long-term ventilated adults and children with tracheostomies. We are currently operating in all major capital cities and all around Australia. And if you need intensive care at home for your loved one, or maybe for yourself, or if you're at home already and you have insufficient support, you should contact us at intensivecareathome.com. On one of the numbers on the top of our website. And if you are in the United States and you need intensive care at home, you should contact us as well. We can help you now in the United States as well. But without further ado, let's just start with today's questions. Let's recap the week that was, and also if you have questions, just type them into the chat pad. And you can also dial in live on the show. I'll share some numbers a bit later once we've gone through today's questions. And then you also have the opportunity to ask questions live on the show. So we'll usually go for up to an hour. I've got plenty of questions to go through. It also depends what questions that you have. And then we'll go from there. So let's just get started. First question this week is from Kimberly. Kimberly writes an email. No, hang on, it's from Amanda. Sorry, Amanda. Amanda writes, "Hi. My fiancé has been in the ICU for 19 days and was intubated pretty much as soon as he got to the emergency department. We have young kids, so I couldn't even go to the hospital as they are too young to be in there unless being seen. They just did a tracheostomy yesterday. He was on propofol fentanyl and Presidex. Now they just have him on Presidex. So he is awake, but still seems pretty much in a fog, which I know the Presidex will do that. Once they are able to take him off that, how long will it take that haziness to lift and him be more alert and aware? He had been sedated so long he didn't even remember what happened. He wasn't in an accident or anything. He had a heart failure episode. Essentially, that's why he went in. Also, does the Presidex make it harder for him to use his limbs, or is that just from not being mobile for so long? Also, do you know if there's any counseling for spouses at hospitals when they're going through something like this? It has been the worst 2 weeks of my life. And since we have 2 young kids, I haven't really been able to process or deal with it at all. We have never gone more than a few hours or so without talking. Our 2-year-old doesn't at all understand why his dad left and just hasn't been back, so he's acting out. And my 9-year-old is worried about everything, so she's very upset. I only have my side of my family helping me. His side hasn't helped me at all, so it's been tough, and I don't want to let him see when I come and visit. I'm just not sure what to expect or do. He will be transferred to a rehabilitation hospital once he isn't on the IV medications, which I will be much happier about, because they will be focusing getting him completely off the ventilator. His heart doctor will be able to see him there, and they will get him physically rehabilitated as well. Okay, great email from Amanda, and let's break this down. So they did a tracheostomy yesterday after 19 days with heart failure and obviously decompensation. And before I go into more details, it comes back to what I keep saying over and over again. The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And I think this email in particular has all of this in it. And I will explain in a minute why. Amanda, you're saying that your fiance had the tracheostomy day 19 into ICU. So a tracheostomy, when you look at the research and the literature, should be done around day 10 to day 14 after the mechanical ventilation with the breathing tube and the inability to come off the ventilator. So now my question is, why could he not come off the ventilator? You mentioned he was on propofol, he was on fentanyl, and now he's on Presidex. Question is, could that have been weaned off earlier? Right? He's got heart failure. Have they optimized cardiac treatment? For example, have they done an ultrasound of his heart? I'm sure they have. And what's his ejection fraction? Ejection fraction is the contractility of the heart. And if that ejection fraction is low, he might struggle getting off the ventilator. But also, if that ejection fraction is low, have they commenced him on inotropes such as dobutamine, milrinone, or have they given him a dose of levocemendin to increase that contractility, improve the contractility of the heart, improve the ejection fraction, and then also simultaneously wean him off the ventilator? Those are missing pieces in your email. Again, that's what I'm saying. The biggest challenge for families in intensive care is that they don't know what they don't know. And how would you know? And if you're not asking for this, they're probably not even telling you what his ejection fraction is. They're probably not even telling you that an ultrasound of the heart needed to take place. What are the results of that? What's the cardiology input here? Right? So first question is, could the tracheostomy have been avoided by optimizing his treatment? I don't know. I don't have enough information. That's again where we come in at intensivecarehotline.com. We either ask questions directly to the doctors and nurses. We potentially set you up with questions, but the shortcut is for us to talk to the doctors and nurses directly, or look at medical records, ideally do a combination of both. Now that he's off the tracheostomy, now that he's off the breathing tube and has a tracheostomy, they should stop the Presidex, unless he is very agitated, not cooperative. If he's combative, yes, he might need some Presidex, but when someone is having a tracheostomy, the next step should be to take off sedation, start mobilizing them, start stimulating them, and start the weaning process of the ventilator. Now, the other thing that you haven't shared, Amanda, is what are his ventilator settings, right? In order for me to tell you, can he come off that ventilator? How long will it take? You should, we need to know the ventilator settings, for example. Also, why is he still on Precedex? Again, I don't know. Is he potentially withdrawing from fentanyl? So when someone is in a prolonged induced coma, and if he was on fentanyl for 19 days, for example, fentanyl is an opiate, a strong painkiller, and fentanyl is also addictive in nature. So if something is addictive and people had it for a long time, they might withdraw. And if they are going through withdrawal, patients might be delirious, they might have tremors, they might have cold sweats, they might have hot sweats, they might have, potentially seizures, and they have a disturbed day and night rhythm. They might go into ICU delirium or ICU psychosis. I don't know whether that's the case, but again, those are all questions that should be asked in a situation like that. Again, do tracheostomy, take off sedation, wake patients up, get them off the ventilator as quickly as possible. Again, have they optimized cardiac function? Have they optimized contractility, especially with heart failure? And if so, what have they done? What are they giving? What have they given? Is he still on a drip for that, like I explained before? So you're saying he's awake, but he still seems to be pretty much in a fog. Yeah, that could be the Precedex. It depends on how much he's on. And it could also be simply a quote-unquote hangover from the propofol and the fentanyl, as I explained a minute ago. Once they are able to take him off the Precedex, how long will it take that haziness to lift and him be more alert and aware? Difficult to say. Again, it depends on how much he's on. Precedex should be clearing pretty quickly as well. But then again, he might still simply be too drowsy simply from a prolonged induced coma. If he's been in that induced coma for 19 days, that I would consider as a prolonged induced coma, and there's simply side effects from that. Takes patients sometimes a long time to wake up, and that might simply be the case in your fiancé situation. Also, if he has heart failure, it'll take time for him and his body to recover. It won't happen overnight. And you're saying he has been sedated so long he doesn't even remember what happened. Yeah, no surprises there. If someone is under sedation for a long time, they don't remember anything, Also, does the Precedex make it harder for him to use his limbs, or is that just from not being mobile for so long? Look, any sedation will make it harder for anyone to use limbs and to start moving again. But then again, when someone is in a prolonged induced coma, there's also muscle wastage, deconditioning, It's almost like people have to start moving again from scratch. So those are all reasons why your husband can't move or isn't moving yet. And then yes, and also I mentioned a minute ago, he might be going through some withdrawal from fentanyl in particular, as being fentanyl being addictive for patients. And the Precedex could help with that. There's clonidine, a drug called clonidine in Precedex, and clonidine can help to minimize the effects of withdrawal. Next, you're asking, do you know if there's any counselling for spouses at hospitals when they're going through something like this? It has been the worst 2 weeks of my life since we have 2 young kids, and I haven't really been able to process or deal with it at all. Look, I'm not aware that hospitals have counselling services for families. I guess that's why they're coming to organizations like ours, where we do the hand-holding for families in intensive care. I think, ask them, of course. I'm not saying they don't, but I haven't really seen any hospitals that have this counselling service. I think that's why you're probably coming to us in the first place, because you've probably seen some content on our website or on our YouTube channel where you think, oh, that resonates with what I'm currently going through. And I believe we are the counselling services, and we, myself and other members of my team, we often counsel families in intensive care and hold their hand and walking them through it step by step. You're saying we've never gone for more than a few hours or so without talking. Our 2-year-old doesn't understand at all why dad left and just hasn't been back, so is acting out. And my 9-year-old is worried about everything, so she is upset. Yeah, it's tough. It's very tough with young kids. I'm not sure whether you want to bring your kids into ICU and see their dad. If you think they can handle it, I don't think it's a bad idea, but it's really up to you. I'm not saying you should or you shouldn't take children into ICU. I think it's really up to your discretion whether you think they can process what's happening, whether you think they are better off by seeing your fiancé, or whether you think they're better off by not seeing him for whatever reason. In terms of you're saying I only have my side of my family helping me. His side hasn't helped me at all. It's been tough, and I don't want to let him see it when I come and visit. Just not sure what to expect or do. In terms of expectations, like I mentioned to you, the next step really is that he should get off all the Precedex, start the weaning process off the ventilator as quickly as possible. Again, that is assuming they have optimized his cardiac treatment. Let me repeat that, because I know it can be a little bit overwhelming when I keep throwing around medical terms. So if he has heart failure, the contractility of the heart would be impaired, right? With that said, they should have done an ultrasound of the heart, and they should have measured his ejection fraction or contractility of the heart. If there is poor ejection fraction, less than 35% generally speaking, he might need to be started on inotropes that help with the contractility or the pump function of the heart. So drugs of choice to improve ejection fraction or contractility of the heart are milrinone, dobutamine, and sometimes levosimendan. If they don't work, then the next step might be to go on ECMO, right? And potentially, again, hopefully he can recover, potentially go, if he can't recover, potentially go on a heart transplant list. Once that's optimized, he should be able to, be weaned off the ventilator, assuming that all other organs are stable. I haven't talked about kidneys or liver. For example, God forbid, if his liver or kidneys are impacted, he might also have a prolonged time to wake up after the induced coma, because if the liver is impacted, maybe the medications are not getting metabolized as quickly as they should be metabolized. The same with the kidneys. If the kidneys are not working, which can happen in ICU frequently, if the kidneys are not working, again, does sedation and opiates still is still in the body, inhibiting him to wake up because they're not excreted through the kidneys. Also, other things that sometimes happen when patients are in heart failure, they might have a Swan-Ganz or pulmonary artery catheter, also known as a PA catheter, to measure cardiac output, cardiac index, and SVR. Again, I'm not wanting to go into too many medical details, but you may want to ask whether he's got a PA catheter and to see whether they're measuring cardiac output, cardiac index. Or if they do that, it would be interesting to find out what his cardiac output and cardiac index are, again, to get an indication how well controlled is his heart failure. Now, then next, you're saying he will be transferred to a rehabilitation hospital once he isn't on the IV medications, which I will be much happier about, because they will be focusing getting him completely off the ventilator. his heart doctor will be able to see him there, and they will get him physically rehabilitated too. Okay, so I'm all for rehabilitation once, you know, he can be off the ventilator, he can have cardiac treatment optimized. You haven't shared which country you're in. I'm not sure whether you're in the US. If you are in the US, your husband might be going to LTAC, and I strongly encourage you to do some research about LTAC. I strongly encourage you to read the reviews online about LTAC. And I strongly encourage you to watch our videos or blog posts or read the blog posts about LTAC. We strongly advise against it. LTACs are the better version of a nursing home, but they're still probably at nursing home level. And I believe LTAC is simply a dangerous place for any patient with a ventilator to be. Your best case scenario and your better case scenario would be to get him off the ventilator where he currently is, and then get him to rehab without a ventilator and a tracheostomy. Things would be so much easier. Also, the cardiac doctor should be able to see him now. The cardiac doctor should give input now. It's got it's got nothing to do with him waiting for rehab. The cardiologist should give input right here and then. So I hope that helps, Amanda. I hope that helps. I hope that answers your questions. And if you need more help, just reach out to us at intensivecarehotline.com and we can go from there. Now, also, let's look at a few things that happened this week where, we keep consulting and advocating for our clients. One quick case that I want to mention is, a lovely client we work with who has their 69-year-old uncle in ICU. And initially, she got told by the intensive care team that he won't have any quality of life and that she should just agree to switch off life support and let him die. And obviously she objected, and stopped them from removing life support. And like many ICUs nowadays, they all say, we'll stop life support tomorrow at 3 o'clock because we don't think it's quote unquote in the best interest of your loved one to live, and it's in the best interest of your loved one to die. It doesn't make any sense to me. And with one particular client, we have then gotten on the phone with the ICU team and we asked, all the pertinent clinical questions. And, the client was told their uncle shouldn't have a tracheostomy. Then, when we started asking all the clinical questions, there was no reason why the client couldn't have a tracheostomy. It was just all made up by the ICU team there without actually giving, information, clinical information. The families are just being told, well, we need to stop life support tomorrow because we know what we're doing and we believe it's quote unquote in the best interest of your loved one to die. Unless you're suicidal, I've yet to find out why people should die. We're all going to die one day, but not by force, hopefully. And then also what hospitals are doing now over and over again, they're trying to get the ethics committees in as quickly as possible. I would say that an ethics committee, from my experience, I label them as, in quotes, death committee. Ethics committees are just committees that sign off everything that the hospital wants to do under the guidance of ethics. I have yet to find out what is ethical about stopping life support, especially if it's against patient and family wishes. I've yet to find out what's ethical about that. Clients are saying that, or this particular client said, the ethics committee and the doctors are so insulting and condescending when I want a question answered. And I'm just reading out this info, but your information is spot on, Patrick. I don't want to turn my uncle off. I'm his power of attorney. since your advice and since you've spoken to them, they've backed off. It's especially interesting to know that hospitals often want to stop life support without a second opinion, right? End of life, I can't stress this enough. End of life does not happen in a vacuum. Right? End of life happens in a legal framework. And if hospitals are telling you, well, we're going to stop life support tomorrow at 3 o'clock, there's a legal framework. It doesn't happen in a vacuum. If they do that, I argue it's illegal and it's not within the law. I am not a lawyer, but I have been involved in many, many cases when you challenge the intensive care team that if they take patients of life support against their wishes, against family wishes, that it's not legal, and they often back off. And I just leave you with that for that particular case. Now, other clients that we worked with at the moment is a client that was in ICU where they wanted to send him to LTAC. That's a US client, where they wanted to send him to LTAC, and we said no, don't give consent to a PEG tube. Yes to a tracheostomy, don't give consent to a PEG tube. And again, the ICU team was very negative. They gave the family a lot of doom and gloom, and we said, hold on, don't give consent to a PEG. Let's just carry on for now in ICU. Let's move him to the ward once he's more stable, and then let's work on taking the tracheostomy out when he's on the ward, or sit in ICU, and lo and behold, 2 weeks later, the tracheostomy is out. No LTAC is needed. And, it goes to show, once again, ICUs want to push out people to LTAC as quickly as possible, especially in the United States. And again, it all comes down to asking the right questions. If you don't know what you're asking, what you're looking for, you're fighting an uphill battle. You really don't know what to do, and you just go with the flow of whatever ICU is telling you. You got to do better than that. And, and I know you will be doing better than that just by watching our channel or my channel and reading our blog. You know that you need to ask questions. You should always question. You should question everything, as a matter of fact. Okay, let's move on. And then another client that we're working with at the moment, one-to-one, is a client that has their father in intensive care for about 3 weeks now, has had a tracheostomy after a cardiac arrest, and is now very slowly waking up. It's been a bit of a long ride there with getting to the tracheostomy because he had an infection. But now that he's got the tracheostomy, slowly waking up, slowly being weaned off the ventilator. So very positive developments there. And, again, we are asking all the right questions. We set up the client with the right questions. And, they feed us the information, and then we interpret the clinical data for them. So that they can ask even more questions. It's a good interaction with any client where we set them up with the questions, and we can talk to the doctors and nurses directly. But it's so much better if the clients ask, because then the ICU team knows they're doing their research. It's very important to show the ICU team you are doing your research and you know what questions to ask. It'll change the dynamics. You'll get better outcomes for your loved one if you know what to look for, if you have someone on your team that can help you. Okay, let's move on to the next question from Haley. Haley wrote an email. She says, "Hi Patrick, I had an experience that was difficult. I was caring for my mother who had Alzheimer's, and since we managed to move closer to New York City, I was able to take her to multiple hospitals, and many just gave me a look like there was nothing that can be done for the evolving loss of function. But I kept hoping and investing in nutrition and vitamins, but once her sudden shudder attacks with her arms extended, I had a private ambulance drive us to a top emergency hospital. I had asked for a stomach feeding tube so I can return home with her for continued care. I refused, as per her request, for the catheter in her private area and refused their request for a needle to be put in her back because they said she had full pleural effusion in the left lung. I thought that was her favorite side to sleep, so they must have seen something different. The doctor, without my consent, moved her into hospice. I told them I wanted to transfer for another opinion because of all the hospitals we had visited. None had ever mentioned this to me, and she has had x-rays done in the past. But he said she had lung cancer and that they want her home with me. So I walked out to her room and not having any suspicion, I saw a nurse inject her IV and I thought they were sedating her for the ride back home. When I began to call medical supply stores for a medical bed, they called me and said she had passed away. I was destroyed and unsure as to what happened. She passed the swallowing test, so they refused to place the feeding tube for her to regain strength. I was wounded and in deep grief, not ever expecting of all she of all things had lung cancer. Maybe she self-sabotaged her health by over-smoking when she realized she had developed what her mother had when she was in her late 20s. But my pain has not gone in the past 10 years because I wonder if they were trusting enough to take such action over covering up an error on their part. I developed permanent sadness I haven't been able to shake off. But if you tell me that hospitals are in a position to make such decisions, even if I was not fully aware, maybe it can help me move on. Thank you. I always learn so much receiving your emails from Haley. Haley, that's very sad to hear. Now, it's hard to say why your mother passed away. It would be speculation for me to say why your mother passed away. The only way we can find that out is looking at medical records, right? I think you've done the right thing by refusing a feeding tube to begin with, especially if she had passed the swallowing test. By the same token, with Alzheimer's, you might, with Alzheimer's, at some point, maybe she can no longer eat and drink, and then you might have needed a feeding tube. With the pleural effusion in the left lung, that might have been a result from the cancer, but I couldn't give you definitive answers without looking at the medical records, which is what we can do for you. You can just go to the hospital, request access to the medical records, assuming you were the next of kin or power of attorney there, and then get access to the medical records. Then we can review them, and then we can give you all the answers that you're looking for. And if she had lung cancer, that would have been seen in either a CT scan of the lungs or in a chest X-ray of the lungs. I can only imagine that you are guilt-ridden now and that you need closure. And again, we can help you get closure by looking at the medical records and see what has exactly happening. Did she self-sabotage by over-smoking? Look, I don't know. What we do know is that the risk to develop lung cancer for a smoker is higher than for the average population, but you can't turn back what's happened. You can only move forward, and moving forward, we can help you because we can help you with a medical record review and find out exactly what's happening or what has happened with your mum, why she died, and whether they've done all the right things and so forth. Now, if you want a medical record review, just contact us at intensivecarehotline.com. Okay, let's move on to the next question. There's an email from Karen, a short one, but I still want to bring it up. Hi, Patrick. It seems the doctors in ICU are avoiding me. I ask questions that they seem to not want to answer. The ICU nurses seem to be slacking off with care and monitoring. Since my husband has been accepted into LTAC, he should be moving this week. Well, Karen, I can see that nurses and doctors are trying to avoid families in this day and age because, families ask a lot of questions, and that's good for you. And you should be asking questions. Are they avoiding you? Potentially. If they don't want to answer the questions that you're asking, I believe there's two possible answers to that. Number one is you are asking the right questions and they're intimidated by it, or you're not even asking the right questions in the first place. So, if you studied my blog, if you studied my video, you will ask the right questions. If you haven't studied my blog, if you haven't studied my videos, you're probably not asking the right questions. Again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's probably exactly what you're dealing with here. Now, if nurses are slacking off because your husband has been accepted to LTAC, I probably agree with that. But, maybe you haven't researched enough material yet. My advice is always that in order to avoid LTAC, do not give consent to a PEC. And before you give consent to a trach, reach out to us. We can give you that crucial second opinion. So, are they slacking off? Possibly. But you could have taken initiative there by not giving consent to a PEC tube to begin with, because then he couldn't go anywhere and you would be in full control. Okay, let's go to the next question. From Natasha. Natasha writes, my husband had a major heart attack and now he is affected with hypoxic brain injury and admitted in Dubai Rashid Hospital. This happened on the 15th of February 2023. He's only 28 years old, and tomorrow, 8th of March, he will be treated with a tracheostomy. Could you please kindly help me to understand this, please? Sure. I'm very sorry to hear about your husband's situation. Now, if he had a hypoxic brain injury and he's not waking up, that probably means that he's struggling getting off the ventilator. It probably means he's struggling waking up because of the hypoxic brain injury. Now, you don't say that he can't come off the ventilator. He might be coming off the ventilator, but he might still need the tracheostomy because he's not waking up. If anything, I think it's a good thing because it'll help him to wake up. It'll buy him time. So I do believe they are doing the right things here. Now, what I will say is this. I would not advocate for him getting a PEC tube if they've asked for this. They might have asked for a PEC tube and you may not even know what it is. We have a lot of families coming to us who say, well, and I've also given consent for a PEC tube, and they don't even know what it means. They don't even know what the consequences are. So do not give consent to a PEC. He can live with a nasogastric tube, which is temporary, whereas a PEC tube, has the perception of permanency about it. So I would not give consent to a PEC tube. But if he's not waking up, then he probably does need a tracheostomy, which is beneficial for him. It'll buy him time. He can be off all sedation, if any, and then hopefully they can start the physical rehabilitation. I hope that helps, Natasha. Let's look at the next question. Okay. My sister has COPD and is oxygen dependent on 2 liters for about 7 years. Prior to her event on December the 30th, my sister was unable to tolerate to return to 2 liters nasal cannulas and left on the trach collar 35% humidification due to thick secretions and transferred to physical rehab. After 4 days of rehab, she was returned back to the hospital due to elevated CO2, and now she's back on the ventilator. She wore a CPAP mask machine at home at night prior to a respiratory arrest on the 30th of December. And through her recovery, no one put her back on CPAP at the hospital. My thinking is the CO2 level has been slowly increasing since they removed BiPAP and then Venotherm and switched her straight to the trach collar right before transfer from respiratory rehab to physical therapy rehab. So she can use the BiPAP, so she can use the CPAP via the tracheostomy just at night. Her O2 sats are fine during the day. She's eating and speaking and tolerating physical therapy. Why can't she just use CPAP at night to prevent hypercapnia caused by hypoventilation during sleep? Furthermore, she's saying she caught the flu and this led to an exacerbation of her COPD. Unfortunately, she respiratory arrested and was in VTAC, but was resuscitated with one shock in the emergency room and placed on a ventilator. In February, she transferred to respiratory rehab to wean her off the ventilator. Then on Tuesday, she was transferred to physical therapy rehab of all mechanical assistance and just on trach collar 35%. Today, she's back in ICU on a ventilator due to hypercapnia. I'm unclear of why she wasn't given pressure support at night or CPAP, which she had been using prior to 30th of December. That's my ask. Trach and CPAP and goal is getting her home. Is this doable? Well, I believe it is doable from what you're sharing with me. The problem here that you are facing is that she's in a rehab facility and they simply don't know what they're doing. You know, I say this confidently and blatantly here that they don't know what they're doing because we've been talking to these rehab facilities for many years. We've been talking to families in those rehab facilities for many years. You know, as soon as patients leave ICU and they go to a rehab facility, again, this is probably very US specific, they are at risk of bouncing back into ICU very quickly, and there's no guarantee that there would be a bed back in the ICU where they came from. You know, and yes, your sister should be able to breathe on CPAP just overnight with a trach collar. But by the same token, you know, can she have the tracheostomy removed? You know, and if CO2 is high, she needs to go back on BiPAP or on CPAP, right? The question is this: can she have the tracheostomy removed? Why does she need a tracheostomy? Can't she just go on the back on the mask with BiPAP or CPAP? That's the question. You know, and then also they need to check an arterial blood gas. They need to check an arterial blood gas. Very important to find out CO2 levels and carbon dioxide and O2 levels as well. Because she would be very drowsy during the day if she doesn't have the pressure overnight. Her CO2 will rise. But what it comes down to is really, again, do not go into LTAC if you're in the US. Do not. What's the alternative? The alternative is to stay in ICU longer. I've just given you an example a minute ago where we worked with a client last week who now has been decannulated by staying in ICU in a particular hospital for longer, you know, and now he's on his way to a quote unquote more normal rehab. And that should be the same here. Do not go to LTAC or to rehab. Stay in the hospital for as long as you can. They can work on getting the trach removed and optimize her ventilation, you know, before she can hopefully go home, and by hopefully taking the tracheostomy out. I hope that helps. I hope that helps. Okay, let's move on to the next question. Hi, Patrick. My dad is in ICU for 9 days and they took him off sedation 4 days ago, but he still has a ventilator. He's 75 and has kidney impairments. He opens his eyes, and when we call him and he's able to move his head, but can't move the rest of the body. We can't seem to get a definitive answer as to why this is happening. Would you be able to help, please? Also, my dad has a buildup of fluid. They are doing physiotherapy in the bed as they can't take him out because he has high blood pressure. They said he's off all sedation, but the nurse said she gave him 200 micrograms of fentanyl when they have to move him. Would this be the reason as to why he's not responding? Potentially. That could potentially be a reason why he's not responding. But it could also be, because maybe it's because of the high blood pressure, maybe because of the fluid buildup, and the question is, how long has he been on sedation for? That's another question. How long has he been on sedation for? If he's not been on sedation for a long time, he should wake up. If he has been on sedation for a long time, he may not wake up straight away. Again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Now, next, you are giving me probably 5% of the information that's pertinent when someone is in intensive care. We would need to know about medical records. We would need to know ventilation settings, pathology results, pathology reports, doctors' reports, nurses' reports. We would need a list of medications, just to name a few. It all comes down to having as much information as possible and knowing what's important. And I understand, most families wouldn't know what's important. I've worked in the environment for over 20 years. It's just comes natural to me. Okay, I hope that helps. I think we're going to wrap this up today. If there are no other questions, if you do have other questions while you're watching this in a replay, just type them below this chat pad, or type them below in the chat pad, or send us an email to support@intensivecarehotline.com, and we'll get to those questions. Now, again, if you have a loved one in intensive care, go to intensivecarehotline.com and call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. Also, have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day in the membership area and via email. Also, if you need intensive care at home, especially if you're in Australia or in the US, please contact us as well. We can help you. We have a physical presence in all around Australia. And we also help now families who need intensive care at home in the US by us finding other providers for them, for our clients. Also, if you need a medical record review or a nursing assessment or a nursing report, please contact us as well. We can help you with nursing assessments, medical record reviews, in ICU in real time, and also after ICU, especially if you're suspecting medical negligence, if you have unanswered questions, or if you need a second opinion. But we strongly encourage to have that reviewed while your loved one is in ICU in real time, so you can have a second opinion in real time. Now, thank you so much for watching. I will do another YouTube live next week at the same time, and with your questions answered. I'll publish some quick tip videos during the week, and I will see you next time. Now, subscribe to my YouTube channel for regular updates for families in intensive care. Share the video with your friends and families. Click the like button, click the notification bell, and comment below what you want to see next. Thanks for watching. This is Patrick Hutzel from intensivecarehotline.com, and I'll talk to you in a few days.